Matthew Holt. I'm here with Bevey Miner, old friend, who is now these days the EVP of Healthcare Strategy and Policy for Consensus Cloud Solutions. Bevey, we're going to talk about last mile to last few yard interoperability and data sharing for people who don't have access to a lot of data. So you guys are in the business of putting unstructured data into more structured format and delivering it to the right place. A lot of people don't have EMRs, don't have FHIR, but they do have fax machines. And that's the kind of business that Consensus is in. So tell me briefly what you do and what problem you're fixing.
So Consensus Cloud Solutions' flagship product is eFax. We're the largest in healthcare faxing. We also recognize that faxing is unstructured data. It is the easiest way to send and receive. It's still unstructured data. When you think about send and receive, very secure. Interoperability is a receiving problem. Many of our customers receive an unstructured fax. A PDF, they've got scanned images. You can't do anything with that data if it's really unstructured. It's still data. It's still a lot of consumption. You can still attach it to something. But many times it requires data entry to pull out anything that is relevant.
So who's using, what types of organizations are you talking about? How are they currently using it, and why do they need it to be more structured and better and whatever? Why does it require the things that you're about to tell me how you do, what you do to it?
So I'm going to give an example. You've got a patient that's leaving an acute facility, a hospital, and they are being discharged with part of their care into a substance abuse facility.
Okay.
That substance abuse facility did not get an EHR under meaningful use. CMS didn't give them the funds. So they are lacking in an ability to have any kind of longitudinal record. They can receive a fax. Many of our customers, substance abuse, critical access hospitals, community clinics, they get an eFax. But they have to data enter it. They have to put it into their system of record. When that data can be unstructured, so we pull out all the demographics, we pull out all of the medications, we pull out the treatment, and we send that as a structured format. And we can map it into any kind of system that the substance abuse clinics may have, the community clinics or the critical access hospitals. That's really important. Many times the hospitals, if they're an Epic hospital, they're going to move forward with FHIR and TEFCA. They're going to send a FHIR message to the substance abuse clinic, to the community clinic, to rural health. They can't digest a FHIR message. So when I say interoperability is a receiving problem, we have to recognize who's receiving it, how can they manage data, should it be pulled out of an unstructured document so they can be consumed on the receiving end. Many of those care settings that I just mentioned, their lifeblood, they live off of referrals. And we've even heard that larger hospital systems are not going to be sending referrals unless the trading partner can absorb something that is more structured. We translate that in the middle. We allow the entire system to connect so that patients that are vulnerable, that are in our underserved markets, their records and their data can follow them.
So one is that your end customer, all those sort of post-acute, non-standard, non-acute hospitals, can exist, can get the data, get the referrals, eventually get paid. What else if you structure the data for them, what else can they do? Can they get paid more? Can they do different stuff for those patients? Can they transfer that data in a different way back to other services those patients might need? How does this improve their world and the world for the patients?
It's a great question. Let's just take, I gave you an example of referrals.
Yeah.
And referrals going to specialties. We got to get the referral to the specialist really fast because they've got to raise their hand and say, I can take that patient. So there are some systems we've even talked to where they have 8,000 different kinds of referrals coming in a given month. And there's somebody having to go through them. By the time they get to the patients haven't moved on. So fast tracking those referrals so the data can be structured. You can look at levels of acuity of the patient. Let's just take home health. Well, home health can't always raise their hand and say, yeah, I can take that patient. You need to really understand what kind of treatment has to be done. Then you raise your hand and say, yes, I can take that patient. We're discharging people at much higher levels of acuity into care settings that aren't going to be interoperable. Referrals is one thing. Prior authorization. Come January 1st of 2027, if you are going to do a prior authorization for a Medicare Advantage patient, you have to send that as FHIR or X12 to the payer. Many of those organizations can't do that. They can send a fax to us that's a prior authorization. Sometimes it's handwritten, as urgent written across the top. Our AI technology, that product is called Clarity, that extracts all this. Our AI technology can extract all the pertinent information from that prior authorization, and it can send it as a FHIR message. So now all of these different care settings can participate in rules that are very daunting and Herculean for them to try and achieve. Referrals and prior authorizations are a couple of use cases that our customers use all the time, because they also are the two that are really problematic with unstructured data and a lot of data entry.
So you are also a policy person. You've been hanging out in Washington, D.C. I know it's we're here in early March 2025, and God knows what's happening to the wider world of policy, even within healthcare. But you've got a little bit of data about how big a problem this is for your clients and what CIOs think about it. So tell us about the study you did.
So we did a study with Chime to ask how...
Are you allowed to mention Chime at HIMSS? I'm not sure anymore. I may not. Okay. Yet another reason why you make it.
So yeah, a collective voice piece of CIOs for hospitals, an organization that does that. And we asked, how important is health equity? Because when I look at this, I look at the patient's journey, and it is an equity journey. It's a journey that patients treated in some of those underserved markets, those providers don't have the same access to the solutions in the large metropolitan IDNs. So we asked them, how important is health equity? Well, 54% said it's very important for them, because those patients are going to bounce back into the hospital.
And get readmitted, may not get paid for, and all kinds of stuff.
They're going to get readmitted. There's going to be a readmission issue to deal with, and they're under value-based care. You don't want those patients to come back. And much of the time is if the data isn't there for the provider to treat them the right way. Health equity has to equal tech equity. So we have got to do the lowest level of digital maturity, but make it relevant and make it useful. And digital cloud faxing does that. Lowest level of secure way to exchange information with our Clarity product, we make that data useful. So 54% of those we surveyed said it's very important to them. And 42% said it's somewhat important. So that's a big percentage. Now, is that because all the CIOs and the CEOs of hospital systems, have a heart or an altruistic way of saying, oh, we need to do things with health equity? No, they're coming from a standpoint of revenue, of remediation, of patient care and the expenses of patient care. So it's costing a lot of money. And when we ask questions we did an HFMA webinar just recently, and we talked about the cost of not treating patients in some of these care settings with the same level of equity. I mean, even when you think about population health, so if the CDC's data modernization is requiring that everything get populated using FHIR, and some of these places cannot, from a surveillance standpoint, send FHIR to the registries for the CDC, that's biased data. It's automatically going to be biased. It's going to be biased for research, because you're sitting over here with a huge amount of unstructured data that nobody wants to really touch. They just think they can start with structured data. Here at HIMSS, there's a lot of vendors that have AI solutions. Their sweet spot and their solutions and their workflow tools work great once it's structured data. When I drill a little bit more and I talk to a lot of these partners of ours too, what do you do with all that unstructured data? Well, they have somewhat of a solution. They don't want to touch it because it's the gobbledygook stuff. It's the stuff that's not really useful in a lot of the things we're seeing at HIMSS. That's our sweet spot. We can touch it, we can do something with it, and then we can put it into any kind of workflow solution.
So you're able for an end substance abuse clinic or critical access hospital, whoever has not got that set of tools, you can basically they can take a fax that you've created structured data of, put it into their system. They can send a fax that you can do the reverse of if they haven't do it for reporting or whatever.
We've got an exchange translation solution that takes all that data. There's the highway that we can connect.
And then, how much room do you think there is? So if you go back to like the people who are now talking about delivering AI-based communication system out to patients, delivering, extraction of care gaps, what all the multiple stuff you're hearing about, for those people from that messy, unstructured data. How much room do you think there is for improvement at the kind of clients that you're working with, as compared to, HCA trying to drive down operating costs by 2% or whatever they're doing with their kind of ambient AI installations?
So I think there's a tremendous amount of value. And the example I gave you is patient discharge from maybe a large IDN down to a vulnerable area of rural health. But we've had a lot of conversations, over 400 conversations of people that have stopped by our booth here at HIM just on day one. And we're learning a lot about the applicability of the solutions that we're talking about. You've got a hospital, a large hospital, on Epic, trying to discharge patients to a point-click care skilled nursing facility.
Yeah.
They don't talk to each other. The patient shows up in the skilled nursing facility hours later, the medications they need to be on, the treatment that they need to have. And that continuity is absolutely important. So even though we have sophisticated systems, not everyone is going to be Epic to Epic to Epic. It's a big part of the pie, but we have to recognize that care delivery is happening in a whole bunch of other care settings. We work with payers. A lot of the payers are saying we need to get structured data so that we can fast track those prior authorizations, and we can also do the urgent ones. They're actually one of our biggest customers and thinking about the CMS rule, because they have only 72 hours to return a Medicare Advantage prior authorization if it's urgent. They need that data in a structured format too. So we're not going to get rid of, we're hoping to get rid of the paper fax machine. That's happening more and more and more. Consensus is a publicly traded company, and we have great growth in our faxing solution. A lot of it is also movement to the cloud. Nobody wants to have on-prem servers and fax servers. So moving to the cloud, getting rid of the paper fax machine, we now know that we can leap even over that unstructured fax document.
So how much of what you're talking about, so you take the fax document, so now you have a document, you can do stuff with the document can be exchanged, using fax technology, but you can do extraction,
right,
get stuff out of it. The other thing that I'm seeing a lot of is people discussing using voice-to-voice, because there's a lot of people in call centers dealing with some of these issues as well. And you're now starting to see voice agents on both sides trying to talk to each other. How much do you think that is either something part of what you're going to get into, or a threat to your business, or is that kind of not so relevant?
When you think about the various ways of communicating, the omni-channel ways, so there's going to be SMS, there's going to be voice-to-voice. We don't do anything with extraction technology unless it's in a textual format,
okay,
but there's always transcripts. There's transcripts with all of these calls.
Yeah.
And our generative AI can package summaries of what exactly are we hearing from a particular transcript that came from voice, or transcripts that may be pulling out soap notes or whatever it might be. We are not using our AI for any clinical decision support, for any kind of treatment support. We augment that by taking data that helps inform a treatment, that helps inform a diagnosis. We don't pull irregular lab results or out-of-range lab results, but our Gen AI can have a rule put in place that says, give me all of my patients that have hemoglobin A1C that went from 5.6 to 6.5. And now the AI knows, all right, let me look for those kinds of ranges. And we can summarize that data coming from some of the voice technology, but it has to be in a textual format. We don't do ambient listening. We don't do any of that kind of stuff.
Yeah, I'm just wondering how what you're talking about is a non-structured to non-structured data, and there are still people calling, receptionists at medical groups and places calling, about prior auth and whatever, talking to somebody who's looking through a paper manual on the other end, and they're which is the analogy to fax, right? I'm just wondering about how much of all that stuff, you discussed the method. How does that get structured? You take the transcripts, you figure out, how do you do the same thing you're doing with faxes? How do you extract information out of the fax and then start running tools over the top of it? And I guess my wider question is, to ask you is, how much capacity do we have for improving these parts of healthcare that have been very inefficient, right, and have been very expensive, and where patient care has been compromised because stuff falls through those gaps all the time? And what's your sense? Do we make this a lot better quite quickly using tools like yours?
I think we have made it in the use cases and the proof of concepts with our customers. We've made it a lot better, but a lot of the answers you have to have is where we see the improvements. What metrics are we using for measurement? You have 200 people that are sitting there reading prior authorizations all the time, just looking for the urgent ones, getting them into some sort of a process for, denial, approval. And we know the American people have said with large headlines all over the place that we have to change this prior authorization process. So we have to do something about it. They are the constituents, the voters for those people that represent our lawmakers.
Right.
There is going to be some movement towards what we're going to do about this. And we just have to get rid of a lot of that data entry and fast tracking. How long does it take? Great metric. How long does it take to find an urgent prior authorization when it used to take this long and it used to take 200 people to do it? The other piece is revenue. You get referrals that are sitting down, not being addressed. The system is losing revenue opportunities. So it's really, what are we trying to measure? And if we just set out to just put in AI for AI's sake and do all the cool bells and whistles without real metrics of measurement, it's not going to be adopted as fast. And Matthew, you and I have known each other for a long time. Whenever we've seen a technology in healthcare that is looking for a problem to solve, it doesn't usually work, right? Except 2 years ago at HIMSS, AI, big announcements, Microsoft Epic together are going to do generative AI. We're going to help diagnose, and everybody was thinking, that's the craziest thing we've heard. The AI is going to diagnose a patient? What if the AI gets it wrong and the patient dies? That was 2 years ago. And a year ago at HIMSS, the industry was like, this kind of has some validity to it, but what the hell do we do with this stuff? There were questions, and hospital systems are like, we kind of have an AI strategy, but we really don't know where to deploy it. Now at HIMSS, just 3 years later, a technology that was looking to solve a problem is solving problems all over the place with measurable ways they are solving problems. And that's what I think the industry did right, is to say, look, I'm a hospital system. I'm not going to just buy this stuff just to buy it. I need to know what is it going to affect. And that's the fastest example I have ever seen of a technology trying to solve a problem that, at least in healthcare, is really solving problems.
Fantastic. Well, I've been doing Bevey Miner from Consensus Cloud Solutions. Bevey, always great to catch up with you and find out what you're thinking. Okay. Thanks for your time.